Okay. Any other questions over gliosarcomas? As I mentioned, most of the unique morphologies that one may read about for glioblastomas really don't carry any significant prognosis. So we've largely abandoned top-lining our cases as such. We may make a mention in a comment that tumors have a more prominent morphology, but it again doesn't really change treatment or prognosis for those patients.
So how common is gliosarcoma?
They're fairly uncommon. One can see them from time to time, and some tumors that have some MAP kinase driver mutations, for example. I'm not sure why those tend to be more spindled in appearance than others, but overall, they're not terribly common. And those such as this one that have heterologous differentiation are fairly rare as well. But you can imagine if you're not given much clinical history and you just receive a biopsy such as this that's fairly small, it can be fairly challenging to sort it out.
Would you please show the glial component and how different does it look from GBM?
Yes, I've been trying to cruise around and find those. They can be extremely focal or more common than not. Here's probably a region that would be I would expect to have fairly robust retention of glial markers. As most glioblastomas can have fairly varied morphology, there is no standard given morphology to the glial component of these tumors, other than it just looks more obviously glial than mesenchymal. And if one is doing a reticulin stain, those would pop out as being in the reticulin deficient regions.
Okay. And the
as
prognosis...
for grading, I'm sorry, go ahead.
Oh, sorry. The prognosis depends on the sarcomatous component or the glial?
No prognostic significance to this whatsoever. It's just an interesting histologic subtype of glioblastoma. They're grade 4 tumors. I've never seen this morphology in a lower grade tumor. You usually will not have difficulty finding mitotic figures, such as there's one right there. And I think this one also had some large regions of necrosis. The abnormal vessels in these tumors will usually be confined to the glial component if one is able to find those, but usually the other high grade features will not be difficult to find.
Okay, thank you.
Of course. Okay, we've recently been handed another grade 4 glioma diagnosis that came into being in the 2016 WHO and has since been refined a little bit. This is, of course, a diffuse midline glioma that's a histone mutated high-grade infiltrating glioma. This has kind of a bimodal distribution of patients who are affected. This that I'm showing here is an example of the very youngest age. So we would expect young children in 2, 3, 4 years of age with primarily pontine involvement and an otherwise fairly low grade glioma appearance. So this section is maybe a little difficult to make out, but you can kind of see the striations at the basis frontis here. It's hemisected and oriented sideways. But if we zoom in a fair bit, one can begin to see that amongst all the different corticospinal tracts that are running through the tissue section, we can see a number of these not only pontine nuclei, but some additional cells that are hyperchromatic and atypical, just kind of percolating through all of the normal structures of the pons. I think there's probably a good region where we're seeing some more of those tumor cells. Mitotic figures would probably be difficult to find in this tumor. We're certainly not going to see necrosis or microvascular proliferation. And so by conventional astrocytoma grading criteria, this might well fit for a grade 2. However, this is a dismal prognosis in these patients. Usually they're not even, considered for surgical or any kind of adjuvant treatment. They're, in many instances, just placed on comfort measures or hospice treatment. As you can imagine, with a tumor that's diffusely involving critical brainstem structures, there's very little that can be done therapeutically, and these patients have a very, very short survival window as a result. And the key driver in these tumors is H3F3A or some of the other histone orthologs that are mutated at the lysine 27 position. So the H3K27N mutated gliomas include this entity. This was formerly known as a diffuse intrinsic pontine glioma. We now refer to all such tumors as diffuse midline gliomas, indicating that they are diffuse gliomas, so they're infiltrating through normal structures. They're present in midline structures such as brainstem, spinal cord, cerebellum, and the thalami can be involved as well. And all of these tumors have the common histone 3 K27 mutation. So if one is encountering a brainstem or spinal cord glioma and your laboratory has that mutation-specific antibody, this is a useful tool to employ. Alternatively, sequencing studies would be highly useful for these tumors. As a result of this mutation, the trimethylation antibody for the same residue, the K27 trimethylation antibody, can also be used as a surrogate marker, and that will show loss of expression in tumor cells if your laboratory, by contrast, has that antibody. Both of those antibodies can be a little bit fickle, so it can be difficult on the ground of IHC alone. But I just wanted to show you this example. This is a lower grade example histologically, so you might not be inclined to call it a grade 4 glioma just on histologic appearances. However, knowing that it's a histone mutated glioma will by default give it that grade 4 designation. And I don't have a good example of the adult counterparts, but many of those that occur in the thalamus and other midline structures are essentially indistinguishable from conventional glioblastomas. So if one does not have those antibodies easily at hand, but we still see high-grade glial morphology on the slide, it's just fine to diagnose it as such, as long as they're either not graded lower than grade 4 or just not graded at all. If the histology is not a convincing grade 4, then ancillary studies can be performed to flesh out that histone mutation. Anyway, so if the bottom line is that if one encounters a glial tumor that's present in one of those midline structures in really any age group, have a low threshold for considering this entity. And if one does not have definitive histologic features of a grade 4 tumor, you can just hold off grading it and call it something non-committal like an infiltrating glioma, and then leave it to ancillary testing to figure out whether the histone mutation is present or not. So I know that's kind of a rapid overview of this new entity, but are there any other questions over this? This is a tumor that we tend to see not infrequently, especially since many older patients, those that we're considering for conventional glioblastoma workup, may have involvement of one of the midline deep nuclei, for example. And so we routinely assay for that mutation in such tumors. And if it does look like a grade 4 and you call it glioblastoma, that's just fine. As long as they are treated aggressively, that will be appropriate. As far as we know, there's no good targeted treatments for these tumors. And the prognosis is not dissimilar from conventional glioblastomas anyway. Okay, if there are no further questions, I want to then transition and talk a little bit about other pediatric type gliomas. These are, as a group, a fairly uncommon group of tumors, if one is not at a children's hospital, there probably will not be many of these that come your way, but in the event that they do, I just wanted to give you kind of a broad strokes overview. May I show some PowerPoint just to kind of supplement this slideshow?
Of course, yes, please.
Let me pull this up. Okay. So just to go over this real quick, I just wanted to borrow a few slides from a few presentations I've done over pediatric low-grade gliomas. If one has a 2016 or even more recent WHO for CNS tumors, one will see a whole host of various pediatric diagnoses with chapters detailing each of these histologies. There's really kind of been a pretty broad shift in practice when it comes to many of these tumor types, and I just want to kind of give you a brief introduction as to why that will be the case as we show some of these morphologies coming up. Oops, going backwards here. Okay, so in the umbrella of pediatric low-grade glioma is one of the biggest umbrella kind of wastebasket terms in all of neuropathology. It really encompasses a very broad strokes cohort of different tumor morphologies, many of which are listed on this slide. All are considered low-grade by their behavior, but more importantly, many of these tumors show pervasive inactivation or activation rather of the MAP kinase signaling pathway. Importantly, irrespective of morphology, so if many of these tumors may show similarity to adult tumor counterparts, this is really a tumor that's very amenable to resection. And in tumors for which a gross total resection is feasible, really irrespective of histology, these are going to be considered almost benign tumors. So one can see the Kaplan-Meier curve is really highly dependent on resection extent. So the reason I show this is that conventional grading criteria for these pediatric gliomas is essentially going to be thrown out the window. If it looks like it's low grade, then we'll discuss how to handle these, but they're a very different beast altogether. Now, this very detailed slide is to show you that for each different morphology that one may encounter in the pediatric glioma realm, the number of driver events that are encountered in these is very, very extensive and promiscuous. And the reason I bring that up is that because there's such a difficulty in assigning well-defined histomolecular clinical entities, there's been a large movement to abandon doing so altogether. So here's an example of the CIMPACT Now update that was issued a couple of years ago on practice recommendations for diffuse gliomas in children and how to top line them. So for example, since a majority of diffuse gliomas in kids, so these are just like we looked at yesterday, tumors that may have either an astrocytic or oligodendroglioma-like morphology, but be in children as opposed to adults. And usually they have low-grade histology, so no necrosis or excessively high mitotic rate or vascular proliferation. They're going to have survival curves just like the one I showed. As a result, this practice has been recommended to abandon really trying to classify these specifically at all, just call them a diffuse glioma, list the driver event when available, and essentially leave it at that. I will say that in our practice, we'll take it one step further and we'll add low grade or high grade to these tumor diagnoses, but really this is not a situation where one wants to apply the adult grading criteria or classification strategies. So while I will show you a variety of different histomorphologies for pediatric low-grade gliomas, by and large, this is the practice that we're going to be moving to more and more, is kind of abandoning labeling them as specific top-line diagnoses and just kind of defer that step to ancillary molecular testing. So with that, I'll now jump back to some of these cases. I'll get rid of that guy. Okay. Before I move on, are there any questions or any points that I should clarify on that previous few slides that I demonstrated? Okay. So here's an example of a tumor that is pretty characteristic. This would frequently be found in the cerebellum of a youngish patient, usually under the age of 18, a cystic lesion with an enhancing neural nodule. Very classic demonstration of a pilocytic astrocytoma. Just kind of give you a broad strokes overview of what a specimen like this may look like. This is a fairly generous resection. One may not get nearly this much real estate to examine, but when you do have it, it can be very, very useful. But you can probably get a sense that there is a somewhat biphasic architecture to this tumor. There are regions such as this here that look a little more compact, and then other areas that are a little looser and more disaggregated. And then if we get in on higher power on some of these, so in the more compact region, there's kind of very minimally atypical cells that are infiltrating through the glial background that have an oligodendroglial morphology. It's a very small round nuclei with abundant perinuclear clearing. But one can also see these darkened astrocytic processes. These are Rosenthal fibers. I think they kind of look like pink carrots sometimes. They're more easily identifiable in these compact regions of tumor. This is a good field that shows you a number of these. Very easily identifiable. So we have Rosenthal fibers, kind of an infiltrative oligodendroglial like cellular component. And then when we move to the looser areas, we can see a few features, not the least of which is that we have microvascular proliferation. So one of the difficulties if one is encountering a tumor that doesn't fit the classic clinical presentation of a pilocytic astrocytoma, but has this kind of morphology, is that this is either a grade 1 tumor or a grade 4 tumor because of the vascular proliferation. So as a result, it's probably a good idea to hold off on calling a tumor a pilocytic astrocytoma if it doesn't fall really, really well within the very characteristic kind of clinical pathologic presentation. We will tend not to call pilocytic astrocytomas if they're outside the cerebellum. Many of those tumors have different molecular drivers that lead to different prognoses, which is, have somewhat overlapping histology. So then what I'm trying to find out here in these looser regions are the cells that are very characteristic of pilocytic astrocytomas, the pilocytes, which have long bipolar processes. And this is, let me look around on the other areas of the slide, see if I can give you a better example. This is probably a pretty reasonable field here. One can see that many of these cells have these long bipolar processes that look kind of hair-like. These can be variably prominent or usually in this looser region of the tumor. They tend to have more elongate nuclei, but they can be somewhat rounded like those in the more compact regions. And so this is a grade 1 tumor. It's considered a tumor that can be surgically curative. And many of these patients, if they're able to have a complete resection that doesn't greatly impact their function, can go on to live perfectly normal lives thereafter. There's rarely need for adjuvant therapy. Occasionally, if, as you can kind of see in some of this more compact areas, that if there is tumor infiltration through adjacent brain structures, there is a risk of local recurrence. And some of these patients can receive targeted therapies in that instance if they're not amenable to complete surgical resection. But this is a very classic demonstration of a pilocytic astrocytoma. And the characteristic genetic lesion in these tumors is a BRAF rearrangement with KIA81549. So usually we will avoid calling even classic tumors pilocytic astrocytomas unless they have a characteristic BRAF rearrangement. So
how do you differentiate it from oligodendroglioma? Is it the age and the site that helps more, or the rosental fiber? Like, I mean, I'm thinking on frozen, if you get it, like, how would you differentiate without mutation analysis?
Absolutely. So one of the key features is just kind of knowing the age of onset. So IDH mutated oligodendrogliomas, for all intents and purposes, do not occur in children. That being said, we have seen them in patients as young as 8 years of age, but in patients below 18 years, it's really a diagnosis that probably should be avoided, especially if one doesn't have support by IDH immunohistochemistry or sequencing, for example. But this will be a recurring theme in many pediatric tumors. Many of them do have this oligodendroglial-like morphology, and it can certainly cause headaches. There's a large amount of morphologic overlap for these entities, and that's part of the reason for revising our practice and trying to avoid labeling any of these tumors without additional molecular testing to provide support. They're just very, very difficult on morphologic grounds alone, especially in a limited biopsy. Now, at frozen section, many times we'll get these very coarsely fibrillar sections of tumor to examine, and so on the smear preparation, they look very, very characteristic. It's almost like pickup sticks, if anybody is familiar with that children's game, but just very, very coarsely fibrillar processes, and sometimes one can even see the Rosenthal fibers on frozen section as well, and that can be a great clue. Here's a good field, for example. So this is not a field you would expect in a conventional oligodendroglioma with these Rosenthal fibers, for example.
Okay, thank
So
you.
I have a question.
Sure.
I have a question. If in frozen section we are having difficulty in differentiating a glioblastoma versus a pilocytic astrocytoma, I mean, the age group will be definitely different, but just in case, how does the management differ in frozen section? And can we just call it glioma? Do we have to label it as low grade, high grade? How do we manage that?
Excellent question. The good news is that the surgical management is the exact same in both cases. So with the rare exception of some non-neoplastic conditions and lymphomas, as I alluded to yesterday, most tumors are going to be subjected to complete surgical resection, irrespective of histotype or grade. So that's really the good news when it comes to neurofrozen sections. Most of them, in my experience, have been more either issues of curiosity. The surgeon just wants to know and to be able to tell the family after the surgery what the diagnosis is, which is slightly irresponsible in my opinion, but it is a pervasive practice. And then in other instances, they may legitimately need to know if what they're examining is lesional or not. I mean, there's been a number of frozen sections signed out in our institution's history as lesional tissue present, and that was all the surgeon needed to know. So I think the risk-reward ratio is skewed such that there really is no need to be super definitive on frozen section. One can even use the term glioma with pyloid features, which is something that we use fairly routinely, even in permanent section diagnoses. If we have a tumor that shows many of these features, such as pilocytic type morphology to the tumor cells, and maybe some Rosenthal fibers, and maybe some unusual vessels. Let me see if I can find some more here. Sometimes you'll just see vessels that are thickly hyalinized as opposed to this endothelial proliferation. but some combination where it may not make perfect sense for pilocytic astrocytoma, that more hedgy diagnosis is perfectly reasonable. And that's another
So
one.
what will be your top line in such cases? Like for the frozen section, what would you write in such cases?
If I had this very tumor, for instance, I would call it a glioma with piloid features. And it has pretty much all of the histologic evidence of a pilocytic astrocytoma. If the clinical presentation fits really well, so this is a cerebellar tumor in a child, I would maybe just go a step further and say consistent with pilocytic astrocytoma, confirmation with ancillary molecular testing pending. There's nothing wrong with that. Glioma, just saying glioma is perfectly reasonable. It tells them everything they need to know. Glioma with low-grade features. I mean, any of these kind of descriptive options are perfectly reasonable. I don't think any one is any better than the others as far as the surgical management goes. But occasionally one does run into tumors that look somewhat like this, but they don't otherwise fit, that kind of standard clinical picture. Maybe it's an adult. Maybe the tumor is in the cerebrum and not the cerebellum. Maybe not all of these diagnostic features are present. In those instances, it's certainly worth backing off a specific pilocytic astrocytoma diagnosis. We are frequently surprised when our molecular testing comes back and they're usually just a mimic thereof. Usually another type of low-grade glioma, but one that does not necessarily have a characteristic BRAF rearrangement. Okay.
Do we need to have the BRAF mutation in order to call it pilocytic astrocytoma?
So it depends on who you ask. I think some of the more pure morphologists may say no. I would say the field is moving towards integrated histomolecular diagnoses. So it's commonly our practice to avoid these very specific diagnoses that have essentially pathognomonic molecular alterations at the time of just paraffin section sign out without the presence of ancillary molecular testing. So as a result, there may be a lot of descriptive diagnoses that we issue, but I think the more that we've learned through the molecular profiling of these tumors, we learn that they're actually a fairly heterogeneous group of tumors, and the natural history can vary dependent on the molecular driver. So, I don't want to call a tumor that's a pilocytic astrocytoma one that may be more aggressive because it has a more aggressive molecular profile. And I mean, that's a more nuanced, complex topic, but for board's purposes, for understanding the morphology, one can certainly rely on those classic histomorphology features, but in practice, we tend to kind of hold off without those ancillary tests in hand.
And what happens to IDH in such cases?
It's never mutated.
Okay.
So usually when we have that kind of histology, our first reflex test is to examine for BRAF rearrangement. So BRAF fish is perfectly reasonable. If one has access to Sanger sequencing for BRAF V600E or other BRAF mutational profiling, I think all of those are very reasonable first-line tests that can be rapidly turned around. Otherwise, panel sequencing or RNA-based fusion detection, just whatever one has at hand would be worthwhile. Okay, so that, of course. Next, what I wanted to show is the close cousin of a pilocytic astrocytoma. One may read about a pilomyxoid astrocytoma. These are far more rare, and they tend to be much more localized to the hypothalamic or suprasellar region, those that are kind of in the quote-unquote optic pathway region. And as I just gave you a broad overview, you'll notice that it shares many similarities with pilocytic astrocytoma. It has this loose myxoid appearance, these long bipolar spindled cells. It's much more prominent, I think, in this example than in the previous. And the cells in this case are kind of arranged in a spoke-like fashion around many of the vessels. Just trying to show some of those earlier. Let's see if I can find a better demonstration of that. Well, as I drive around, we'll see them. But noticeably absent, we don't see the characteristic biphasic architecture. And I know we haven't had a chance to review the entire slide together, but you can take my word for it that there aren't Rosenthal fibers in this section. And so this would be, again, a glioma that has these, quote unquote, piloid features. They have pilocytes present, but not all of the features of a pilocytic astrocytoma. And when one does molecular testing on this, here's a good arrangement of the cells around the vessel here. One may see a number of molecular events. This one is certainly not nearly as married to BRAF rearrangement as pilocytic astrocytoma, but these tend to be more aggressive. So whereas pilocytic astrocytomas are classically graded as WHO grade 1, pilomyxoids tend to be more grade 2. So these are rare tumors. We very infrequently see them. Again, this is a tumor type that we probably would avoid a specific top-line diagnosis because this histomorphology can overlap quite a bit with a few different entities. And the bonus points for being specific is just not there. If we call this a low-grade glioma with some piloid features and discover a driver event that's in our MAP kinase pathway that we expect, so be it. But it certainly doesn't have all of the classic features of pilocytic astrocytoma, namely those that I've detailed here. And like I said, it tends to be very specific for that sort of suprasellar hypothalamic anatomic location. Any
And
questions?
there is no anaplastic version of these tumors, is there?
So again, that's a somewhat controversial concept. I would argue those tumors for which one may see anaplastic features are probably something more like a GBM that just has an unusual morphology. I've actually seen a fair number of cases of bona fide glioblastomas that they're in the right age population. They're in older adults. They're IDH wild type, but maybe they, for whatever reason, have a MAP kinase activating mutation, maybe in BRAF, maybe in some other gene in the pathway, and it just gives them this type of morphology, but they're otherwise indistinguishable from glioblastomas in terms of the natural history. So I don't really think of an anaplastic pilomyxoid or pilocytic astrocytoma as being a real entity. I think those are usually some other tumor that's masquerading as such. So I avoid that diagnosis at all costs. But you will see that in the literature, and some institutions will make those diagnoses. So it may come on some reports from time to time.
Mm-hmm. Thank you.
Of course. All right. As we're running a little short of time, I just want to cover a couple of other tumor types. So this, for example, we're now going to discuss a dysembryoplastic neuroepithelial tumor. It's an unwieldy diagnosis, also known as a DNET. This is one of the very characteristic epileptogenic tumors. So these patients are usually younger patients, children, teenagers, young adults. They're usually presented with a history of seizures that's medically refractory. And at some point in their clinical history, they'll get imaged and they'll see this very sharply demarcated, cortically based space occupying lesion. So you can see from this en bloc section, sorry, this is a sulcus. So you see the leptomeninges, here in this tissue fold. And here's an expansile mass. It's looks like it's kind of localized within the gray matter and just kind of filling up this region of the cortical ribbon. If we look on higher power, we can see this tumor again has oligodendroglial-like morphology. This will be a very common theme in many of these tumor types. They're just kind of too many and coursing through the cortex. This is one of the unusual tumors in that most gliomas are centered in the white matter. This one is in the gray matter. And so as a result, the mucinous pools that are frequently associated with this tumor type, here's a good example. You can see this kind of microcystic appearance of the lesion can envelop existing background neurons and produce this highly characteristic so-called floating neuron appearance. In some cases, it looks just like a neuron has jumped into a swimming pool of mucin. Here's a small one, for example. Here's another example. But this is pretty much how these tumors look. Usually these are WHO grade 1 tumors. Again, there are some other kind of low grade diffuse gliomas that can have somewhat similar morphology. So, you know, this is always a consideration in a differential that includes other entities. But for the purposes of maybe a board study or just kind of general knowledge, this is a very classic demonstration of what these tumors look like. These tend to have FGFR1 tandem duplications of kinase domains if one has a molecular bent. But that's not the only mutation that these tumors can have. And there's many other tumor types with other alterations that can have this kind of cortically based oligodendroglioma-like morphology that don't as of yet have good names to them. So this is just kind of one in the spectrum of tumors that can look like this. The very indolent Ki67 in these tumors would be extremely low, maybe 1-2%, something like that. If one is doing glial markers, all of these neurons in the background will be negative. They will instead express mature neuronal markers if one is including that in the panel. But otherwise, that's a pretty classic appearance for this type of tumor. So I think we'll wrap up with that today. Are there any questions over this or any of the other tumors that we've looked at this afternoon?
Do we see Rosenthal fibers in DNET?
We should not.
Okay.
That being said, if one does see that, we'd probably back off the diagnosis. You never say never. Rosenthal fibers can be seen in regions of extreme reactive change, so long-standing, space-occupying lesions like an arteriovenous malformation, or maybe a long-standing infarct or something like that. One may see Rosenthal fibers at the periphery, so they're not necessarily associated with neoplasia in and of themselves. But I've never seen them and wouldn't expect them in this particular tumor type.
All right. Does anyone have any other questions? Okay. Thank you very much, Dr. Meredith. It was a wonderful session. I wish that I would have recorded it from the beginning. My bad.
No. That's okay. That's okay.
Yeah. All right. Thank you very much.
Thank you very much. You all have a good evening.
Thank you.
Yeah, bye-bye.